Hello everyone, this is Dr. Eminis again. Let us now study about peripheral neuropathies. We'll study about the patterns of neuropathic disorders that would be easy for us for diagnosing what is the cause of that peripheral neuropathy. Okay, so pattern 1, symmetric proximal and distal weakness with sensory loss. Where do you find that? In GBS. Okay, there will be proximal distal weakness with the sensory loss, and also in CIDP. Okay, next is symmetrical distal sensory loss with or without distal weakness. Okay, so one is your diabetes, cryptogenic or idiopathic sensory polyneuropathy, without loss. There's a with or without loss, predominantly there is a sensory deficit. Drugs and toxins, family disorders, Charcot-Marie tooth disease, hereditary sensory and autonomic neuropathy, amyloidosis, etc. Next is asymmetric distal weakness with sensory loss. Okay, asymmetric distal weakness is there with sensory loss. So with involvement of multiple nerves, it could be like multifocal CIDP, vasculitis, cryoglobulinemia, amyloidosis, sarcoidosis, infectious disease like leprosy, Lyme disease, hepatitis B, CE, HIV, CMV virus, hereditary neuropathies with liability to pressure palsy, that is HNPP, and tumor infiltration with involvement of only single nerves or regions, that is compressive mononeuropathy, plexopathy, and radiculopathy. Next is asymmetric proximal and distal weakness with sensory loss. In that, diabetes, meningeal carcinomatosis with lymphomatosis, sarcoidosis, amyloidosis, hereditary plexopathies, and idiopathic causes. Next is asymmetric distal weakness without sensory loss. So, if we see in upper motor neuron findings, there is upper motor neuron diseases, and without upper motor neuron findings, human lesions, then progressive muscular atrophy, juvenile monomelic amyotrophy, that is Hirayama's disease, multifocal motor neuropathy, multifocal acquired motor axonopathy. Okay. Now next is symmetric sensory loss is there, distal areflexia with UMN findings. In that, B12 deficiency, vitamin E, copper deficiency with combined system degeneration with peripheral neuropathy, chronic liver disease, hereditary leukodystrophies, hereditary spastic paraplegia plus, that is HSP plus. Next is symmetrical weakness without sensory loss. Okay, only weakness is there. Then you will get in spinal muscular atrophies. If the proximal and distal weakness both are there, but only distal weakness is present, then you have to suspect for hereditary motor neuropathies and atypical Charcot-Marie tooth disease. Next is focal midline proximal symmetric weakness. If the neck extensor weakness is present, that is case of ALS. If bulbar weakness, that we know ALS will have bulbar weakness, isolated bulbar ALS, Kennedy syndrome, that is X-linked bulbospinal sinomuscular atrophy. Next is bulbar presentation of GBS. If diaphragm weakness is there, that is goes towards ALS diagnosis. Next is asymmetric proprioceptive sensory loss without weakness. It will happen in sensory neuropathies or ganglionopathies like cancer, Sjogren syndrome, idiopathic sensory neuropathy. It's a possible variant of GBS only. Cisplatin and other chemotherapies, vitamin B6 deficiency, toxicity, HIV related sensory neuropathies and all. And the last one is autonomic symptoms and sign. You have to consider the neuropathies associated with prominent autonomic dysfunction, like in the cases of hereditary sensory and autonomic neuropathy, amyloidosis, diabetes, GBS, idiopathic pan dysautonomia. This is also a variant of GBS only. Porphyrias will present with autonomic dysfunction, HIV, vincristine and other. So vincristine is here. Okay. So these are the different patterns in which it will make us easy for the diagnosis of cause of peripheral neuropathy.